I feel like if I had heard that presentation, I might have structured my talk differently, but I'm glad you gave it, because I think it does raise a lot of questions. Some of the things put forward by the U.S. Catholic Conference may leave you with those questions, and I encourage you to ask them during the Q&A, because there are answers to all of them. I want to thank the League of Women Voters. I want to thank Kay for holding this important conversation. Since I joined Compassionate Choices in 2015, I've traveled the state from the North Country to Long Island, from Buffalo to Brooklyn, and everywhere in between, having conversations like this. I think it's important that if New York is considering making such a big change to our laws to allow medical aid in dying, that we ought to have robust public debate and conversations about this, and I hope to be able to answer some of the questions that you have after these presentations. You know, in order to truly understand this issue, I think it's important to think about it from the perspective of people who are suffering. And I was grateful for Dr. Bem's presentation. And I thought tonight about whether I should tell you a story about Jay Callio, who was a transgender man living in New York City in public housing. He was a hospice volunteer during the height of the AIDS epidemic, and he was a real fan of palliative care and hospice. And he found himself in a premier medical institution in the middle of Manhattan, and he had recorded a video for us shortly before he entered the hospital, talking about the way that he wanted to die. And he ended up dying in the exact opposite way, screaming in pain. And these were the last memories that his partner carries with her now, is the memory of the physicians and the nurses rushing around him, trying to figure out how to relieve his pain and not being able to. Or I could tell you about the woman that I met at the New York State Fair last year, an African-American woman from Yonkers who cared for her daughter in the last year of her life as she suffered from breast cancer, and died begging her mother to help her leave this world, and her mother feeling guilty that there was nothing that she could do at the end. Or I could tell you about the man from Long Island who sat down with his state senator a few weeks ago, and the first thing that he said was, "My mother asked me to shoot her." Or about the 9/11 first responder, Douglas Greenwood, who shot himself at the entrance of a public park on Long Island right before Christmas, because he could no longer bear the agony that he was facing, sleeping with an oxygen tank for 10 years and just seeing everything about his life decline. He told his best friend that he wanted to make sure that no one thought he was crazy, and that he had a wonderful life and it was time to go. But I thought it might be better, because I had just visited Buffalo, New York a few weeks ago, to give a talk for my friend Yvette. Yvette and I were in graduate school together. She took me under her wing when I went to Buffalo for graduate school, because she was older. She'd been in the program for a few years, and she was my husband and my real estate lawyer when we bought a house for the first time. And she's kind of the center of her community in that town. She's a public interest lawyer, and she seems to know everyone in that town. She asked me to come to Buffalo to talk to her about what her options were at the end of her life. When she was diagnosed with anal cancer, she asked her doctor, "How are we going to beat this?" And her doctor prescribed an aggressive course of treatment that she underwent. She thought she had it under control, and then last year she was diagnosed with stage 4 anal cancer. And she intends to live life to its fullest until the end. She has been undergoing the new treatment that you may have heard of, immunotherapy. It's taking quite a toll on her, and she's considering a second round of it, seeing as how it does allow her to bounce back for a while and live more fully. But she invited me to come out because she and her doctor at Roswell understand that those treatment options at some point will end, and she wants to know what faces her. Now, it's my job to talk about death and dying all the time, I'm the life of the party. I'm always talking about this issue. I think it's important for us to talk about it, but it's really, really hard to talk to your friend about her death and her dying process. But in doing that, I think it provides a really helpful framework for thinking about why New York needs to adopt a medical aid in dying law. So I'm going to share with you what I shared with Yvette and her friends. There are 5 options available to people who are dying here in New York right now, and I'm going to talk about each one in turn. The first option is to avail yourself of all medical treatments and interventions until the end. Everyone has the right to seek all available medical treatments and interventions. My father did that when he was diagnosed with stage 4 lung cancer, even though in retrospect, it's likely that some of the chemotherapy he received at the end shortened his life and may have interfered with the quality of his life at the end. But he was a Marine, he was a fighter, he didn't even want pain medication. And you won't hear me refer to medical aid in dying as death with dignity, because my dad died with dignity, because he died the way he wanted to. He was at home, surrounded by loved ones, and making his own choices. But back to Yvette. Yvette is lucky. She has good, although not excellent, health insurance. I've watched her fight with her insurance company for coverage of her care, and she's still fighting for coverage of experimental drugs and access to clinical trials and payment for her insurance company for treatments recommended by her doctor. And I think about the arguments about our for-profit healthcare system as an argument against medical aid in dying, and I have to scratch my head because we live in a system that denies care to people with or without a medical aid in dying law. People are fighting for their lives now, and in fact, some of our opponents of medical aid in dying are actually putting their lives on the line in DC to fight for health care for all of us. So it's a strange fact to contemplate, that one would think that you should be opposed to medical aid in dying because of our for-profit healthcare system. No, we should all be fighting together to make sure that we do have access to care, because people are being denied now. Anyway, so back to Yvette. At some point, her and her doctors acknowledge that the treatment options will run out. And so what's available then? Well, everyone has the right to discontinue or refuse medical treatment at any time during an illness. So when Yvette has had enough, she has the right to say to her doctors, I don't want to receive any more treatment. Even life-sustaining treatment, a ventilator, a feeding tube, IV hydration, antibiotics, all of them can be refused or stopped at any time, and the decision can be made by a health proxy or through an advanced care directive. Once you stop receiving care, it's likely that you're going to need palliative care at any time that someone is receiving care, or when they decide to discontinue care, there's an option to receive palliative care. Sometimes referred to as comfort care, palliative care is a specialized approach to the treatment of patients with a serious or life-threatening illness. The goal of palliative care is to provide relief from the symptoms, pain, and stress of serious illness. While palliative care can be provided alongside curative treatment, the goal is different, and that goal is to provide pain and symptom management. It can involve the use of medication or alternative therapies such as massage, acupuncture, aromatherapy, all of those methods to bring comfort to the patient. One palliative care option available to those who also have a terminal prognosis, and one that in many cases is restricted to those who choose to forego treatment, is hospice. Hospice is a specialized type of care for those facing a life-limiting illness. Their families and their caregivers are also recipients of hospice care. It involves a team of professionals working with a patient in their own home or in a home-like setting, concentrating on managing the patient's pain and other symptoms so that the patient can live as comfortably as possible and make the most out of the time that remains. It addresses a patient's physical, emotional, social, and spiritual needs. And just as important as helping the dying person, hospice also helps the patient's family caregivers. One philosophy of hospice care is that the quality of life is prioritized as importantly as the length of life. The vet is very lucky. Hospice Buffalo is excellent. They've been around a very long time and they know what they're doing. So she's in good hands, as were my family and I when my father received hospice care. Now, my father, when he was given the diagnosis of 6 months or less to live, he died 2 days later. And in fact, that's where you get the statistic that the majority of prognoses are wrong. If you actually look at the research, the majority of prognoses are that people are going to live longer than they actually do. So 85% of the time, doctors actually give the wrong prognosis, but in the other direction. Now, there are certainly people who outlive their prognosis. I'm Catholic, actually. I call that a miracle, and I think we can all be grateful when that happens. It happens. Everybody's body is different, and a prognosis is a best guess. For some patients with certain kinds of diseases like cancer and those who are receiving hospice and palliative care, they need to take additional steps to relieve prolonged suffering endured as part of the dying process. There are 2 additional options in New York State that are available in those cases, and I'll talk about each. The first is voluntarily stopping eating and drinking, otherwise known as VSED. VSED is a conscious decision to refuse foods and fluids of any kind, including artificial nutrition and hydration. The option can be chosen by a decisionally capable adult who has the ability to eat and drink but refuses because they want to hasten the time of death. It's a legal option anywhere in the United States. It's been sanctioned by the Supreme Court. It can be sought at home or in a care facility, but should be medically managed to minimize discomfort. It's not an easy option, stopping eating and drinking. It's difficult for a family, and it's difficult for an individual, even though for some of those who are dying, a loss of appetite and a desire to seek hydration is a normal part of the dying process. Discomfort from withholding food and drink can be quite uncomfortable. A determined and well-informed individual with significant care can choose this option and die a peaceful death. But for some, VSED is a choice that can result in that's not so peaceful. Sid is a man from the lower Hudson Valley. His wife, Stacy Gibson, speaks about Sid's death a lot in the context of VSED, and what she says is this: it took him 12 days to die. Can you imagine not eating or drinking for 12 days, just waiting to die? While the good people at hospice did all they could to keep him comfortable during that time, Sid developed terminal agitation, which resulted in extreme verbal and physical outbursts, making his final days horrific and frightening. It was not peaceful, and it was not the death that Sid wanted. As a case like Sid's demonstrates, VSED is not for everyone. Another option, when standard hospice and palliative care aren't enough to relieve suffering, is the last option that we have legal in New York, and it's called palliative sedation. Sometimes called terminal sedation, it involves being medicated to reduce consciousness. Palliative sedation is an end-of-life option that is practiced in very rare circumstances. A person remains unconscious until death while food and nutrition are stopped. Sedation may bring relief for extreme pain and suffering. However, it may not totally relieve symptoms. Providers have often described palliative sedation as more of an art than a science. You give too much, and you hasten death, which is not allowed under the law. You give too little, and someone may wake up disoriented and in pain. And that's exactly what happened to a woman named Jennifer Glass, who was an advocate for California's End-of-Life Option Act. She petitioned the legislature to change the law, and they did. But before she was able to avail herself of it, she chose palliative sedation as the only option left to her. Her husband is now a strong advocate for medical aid in dying across the country because he saw what happened with Jennifer, as Jennifer woke up 3 times during the course of her palliative sedation, begging for relief. Which leads me, of course, to say that we need something more. We've seen an evolution in end-of-life care with the development of hospice and palliative care in this country, but now we need to take another step, and that is to authorize medical aid in dying for decisionally capable adults. Physicians in 6 states and Washington, D.C. now allow this option, and clinical practice guidelines for how to prescribe and manage patients who ask for this option were published in the Journal of Palliative Medicine in 2015. In the 20 years since Oregon first authorized medical aid in dying, there's not been a single instance of abuse or coercion, and not one instance of abuse or coercion in any of the states that now authorize it and have begun to collect data. Those who oppose medical aid in dying often offer anecdotes or talk about hypothetical fears, and I can say that we've done research into all of them. No one is more invested in the success of this law than an organization that's mission is to improve end-of-life care. The New York legislation has the same core protections as the Oregon bill and every other state that has passed the law in this country. The bill was introduced in 2016 in its current form, and it passed the Health Committee that year. It contains over a dozen safeguards. 2 physicians have to confirm the terminal illness and the 6-month prognosis. 2 witnesses have to be present for the request. There are penalties for fraud and coercion. There's a referral to a mental health professional if either doctor thinks that the person doesn't have the capacity to ask for medical aid in dying. There's a requirement of counseling for all the options that are available to people, including pain management, hospice, and palliative care. Neither age nor disability qualify someone to receive the medication. And I think, very importantly, no one is required to participate, neither the patient nor the doctor. The only time you get medical aid in dying is if you ask for it, and even then, there's sort of a funnel effect. There are a lot of people who talk about the way that they want to die. Fewer request the medication, fewer qualify for the medication, and then even fewer take the medication. I think all of these safeguards and all of the data that we've seen for the past 20 years are why the number of professional associations that have endorsed the practice across the country has grown, and now includes the American Academy of Hospice and Palliative Medicine, the American Public Health Association, the American Medical Women's Association, and the American College of Legal Medicine. 10 state medical societies over the past 18 months have lifted their opposition to medical aid in dying. It isn't for everyone. In fact, very few people actually ask for it and fewer use it. I think that Governor Jerry Brown, a practicing Catholic, and the Governor of California said it best when he signed that state's End-of-Life Option Act into effect in 2015. He said, "In the end, I was left to reflect on what I would want in the face of my own death. I do not know what I would do if I were dying in a prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others." I look forward to the day when our own governor signs aid in dying legislation, and I invite you to join me in the work to make that happen. I know that the League of Women Voters is deciding whether or not to support allowing decisionally capable adults to choose medical aid in dying. I hope that you do. But if you agree as individuals, I invite you to sign our petition, take some of our materials, and join us. Thank you.